Well, howdy YouTube family, it's Bold CRNA coming to you again with another week's topic. So this week we're going to talk about what it's like practicing as an independent provider. I've recently transitioned into doing independent practice and a lot of outpatient work, and you guys who follow me on Instagram and stuff have been asking me a lot of questions on my stories that I post daily. So we're going to get into the details today. So I've been a CRNA for 2.5 years. What's the big difference? I've been practicing in these hospitals. I even practiced in a pretty independent hospital for my first job out of school with about 8 or 9 CRNAs really running the show. There was a physician anesthesiologist involved in the group, but he was mostly an administrator that didn't really do much clinical work. So what's the difference in me doing independent practice now? What's it really feel like? Well, this is actually the first time that I've been a 1099 independent provider, which just means I'm not an employee. An employee is a W-2 taxing, lingo. But a 1099 means you're an independent contractor. You're pretty much working for yourself. And when you mix 1099 with a group that's essentially saying, hey, we just need your help on certain days when you're available, no commitments, no benefits, here's a day rate that we're willing to pay you for a set amount. Typically you'll work 6 or 8 hours in a day, and this is the amount we'll pay you for those days. If you work beyond those number of 8 hours that we told you we'll probably need you, then we'll pay you a negotiated hourly amount. And so that's kind of what it is to be an independent contractor. You cover all of your own benefits, you cover everything yourself. You make your own schedule, or at least you let them know what your availability is, and they tell you if they need you those days. And if they don't need you those days, you may have an agreement with a different group somewhere else, or a different clinic, or some other thing that you're doing on the side, and you may work and do that a few days. So that's kind of the idea of like the infrastructure of why this is a different schedule versus when you're a W-2 employee. Because a lot of you guys who have worked as nurses or any kind of job before, you know as an employee, you don't make your own schedule really. You don't decide if you're going to work this week or not work this week. You don't tell them, I'm going to work for this much today and that's how much you're going to pay me. It's a lot more structured, and you're their employee and they control your schedule. They control when you can go on vacation. They control those aspects of your life. So in independent practice, you're essentially controlling everything yourself, but the flip side to that means they don't owe you anything either. So there's not the security or the safety of your W-2 position. So that's kind of the infrastructure of it. But let's talk about the day-to-day work. What's it like just working independently? As CRNAs, day one of your training, you're pretty much told you're being trained as an independent, full practice anesthesia provider, and you will be held to the expectations and understandings that you know everything that you're supposed to know that any other anesthesia provider out there in the market will know on this topic. And you're never expected, the answer on the test is never call someone else for backup or call a physician anesthesiologist to come tell you the answer. It's never the answer on the exam. Try writing that in and see what they tell you. So I say that to let you know that it should be natural for you once you graduate to be leaning towards independent practice. Even if you work in a group and you collaborate with other people, you should never be collaborating with other people using them as a crutch for a weakness. You should never be working with other people and expecting them to cover your blocks for you because you don't know how to do them, or do your central line for you because you're not capable of doing them. Or being a backup for you for your induction and emergence because you're uncomfortable or not confident in those skills, or dealing with emergency situations because you don't feel confident in dealing with those situations. Your training should have prepared you well enough to handle all that on your own before you graduated. And if you don't feel confident in those things, you should be actively working on those things to become confident. That's not saying that you should never ever ask anyone for help, that you should always act like you know the correct answer and never rely on anyone, because that's not realistic. You should always be open to knowing your resources, knowing your colleagues, knowing people you can call on, whether you've been doing this 10 or 15 years and you're completely independent or not. There will be situations that will come up where you should have a lifeline where you can call someone and say, hey, this weird thing's happening, what do you think's going on, or something like that. But it shouldn't be your default all the time. So independent practice for me is pretty natural. Even when I practiced in a group with quote unquote supervision. I didn't address it like supervision. I didn't expect, supervision. I worked very briefly in medical direction, which is to me extreme micromanaging, and I can't work like that. So I left that per diem position pretty quickly. Medical supervision is much more loose and much more just like a loose collaboration, and typically if they feel like you're competent and they understand that you know what you're doing, they usually just leave you alone and let you do what you're doing. So it's a much better as a CRNA to work in that kind of environment that's healthy and supportive and pro CRNA, because that gives you the ability to kind of stretch your wings, especially as a new CRNA, so you don't feel stifled and you're able to practice to your full extent. And then from there, the transition to fully independent solo on your own isn't that different, because essentially you're just taking away the safety blanket that was hanging out in the back room that you didn't really call on or really need, or maybe you did a couple times but then realized from a few times of them coming to help you, you realize, oh, well, what they thought to do is the same thing I thought to do, and we both just did it together, and everything was fine. And you realize, oh, okay, so you start building up your confidence and realizing, like, okay, I do know what I'm doing here. I do understand, the appropriate things to do in odd situations and stuff. And life experience. Life experience is going to teach you things, and by life experience, I don't mean like dating world and things. I mean life experience in the anesthesia world is going to teach you stuff. You're going to learn stuff on the job doing things. You're going to have experiences, and the more experiences, the more things that happen to you, the more you're going to say, oh, okay, so next time I may use half of that amount of ketamine and do more propofol, and this type of patient probably would do better with a little glyco before we start, or something like that. Those things start teaching you habits that make you better, more skilled, more smooth, and more comfortable. So after 2.5 years of practice, I have gone independent. So now I go in to a practice where there is no one else there but me. There may be 1 or 2 other surgeries going on that day, or maybe nothing else going on that day in different OR rooms in this outpatient surgery center that I go to. I go to a few different places, but one primary place that I typically go to. And yeah, at all these places I go to, I'm either completely the only anesthesia provider in the whole facility, or there's a couple other people there. They could be CRNAs, they could be physician anesthesiologists, but they're also doing their cases themselves. So each of you will have a room that's assigned to you, like an OR room that you're all covering, and you're covering those cases. And so you may pass them by in the hallway and say hello or something, but you're all there just doing your jobs as anesthesia providers. No one's supervising or managing any of you. So that's the interesting aspect of completely solo practice, is when you go in the mornings, you realize everything you're doing today is your plan of action. It's going to be your responsibility to do everything appropriately. If the patient needs a block, there's no one else to do that block but you, so you need to be able to do those blocks. What I would tell you is, in advance, tell whoever the scheduler is, if you aren't comfortable doing blocks, which is not something to be ashamed of, blocks can be a little tricky, and there are certainly people, physicians and CRNAs, who don't feel that great about blocks, or at least not all blocks. So you should tell the scheduler in advance when you're doing independent practice, like, hey, I don't really feel comfortable at pediatrics under 2 years of age. I don't really feel comfortable with these types of blocks. You need to let them know who the schedulers are. Like, these types of situations I'm not the best with, so probably not a good idea to put me in those rooms. And then maybe work on some blocks, maybe go to a block course, which is what I did. I did a lot of blocks in training, but because I worked in some supervision type practices where there was block teams and it was big hospital systems and there was trainees who were doing a lot of blocks, I did a few blocks here or there, but it was hit or miss when I would do a block. So after a couple years of not consistently doing a lot of blocks, I had to do a refresher course that I paid a couple $1,000s for, that taught me, pretty intensive refresher on the 7 or 8 core blocks that you do all the time in ortho and other types of practices, especially outpatient surgery centers. And then once I got done with that, I felt very comfortable with blocks again, and I have been since then. I've done blocks frequently every week in practice, and I feel good about them, and the patients have great pain relief afterwards, and they do very well with them. So, the idea is, in independent practice, no one's going to tell you no, because you're licensed and trained to do something, so you can do it, But if you actually are not competent or feel very comfortable doing it, don't do it. That should be an obvious thing, especially if you graduated and got licensed. That kind of concept should already be ingrained in your head, but I'm just going to remind you of that. And for those of you who aren't CRNAs and wondering about how that works, the idea is you should know when you don't know how to do something, and you should not do that thing, and then go seek out education and brush up on that topic or that issue that you need to know more about. Another important thing when you're transitioning independent practice is realizing that the safety equipment and the drugs and all these kinds of things that maybe in the hospital system you're used to anesthesia techs and pharmacy techs and all these different people, ancillary staff who are around to make sure everything's stocked for you. They're checking your machines, they're making sure you got triple the circuits available in the room, they're making sure your ambu bag is there, they're making sure a lot of assistive personnel in the hospital system kind of are team members that help you. And honestly, in training, you're kind of told and you are trained to do all of this on your own. But in practice, when you get in a hurry and you work in a big hospital system and you know that there's 3 anesthesia techs there this morning and they've all checked the rooms, you'll probably quickly glance to see that they did the machine check, or you might do a quick circuit leak check or something, but you're usually not as intense in big hospital systems where you've got so much backup assistive help. When you're in an ambulatory surgery center where it might literally be you, the surgeon, the circulator nurse, and the scrub tech, a pre-op nurse and a PACU nurse, and a secretary, and that's like the whole team in that facility for the day, you're going to check your machine. You're going to check your oxygen flow rate. You're going to check your ambu bag to make sure it's there. You need to be checking that your succinylcholine is in like the top drawer ready to go. You're going to be making sure your endotracheal tube is styletted and prepped and ready, and that your light is functioning on your Miller tube blade, and everything is good. You need to make sure when you're independent practice that all of these things are covered, because you are the only person responsible for those things. And if you don't check it, nobody checked it. And that patient deserves the safety coverage of knowing that you're doing all the extra steps you need to do to make sure everything's good. That includes making sure the facility's set up for malignant hyperthermia. Do they have a malignant hyperthermia cart here? Do they have an emergency airway cart here? Do they have video laryngoscopes available? You have to make sure all these things are set up. Is there an LMA available in an emergency situation? So that's a core difference. You're going to be hyper vigilant to all of those aspects. Beyond that, you're going to find that in outpatient independent practice, things are very production oriented. So you're going to be getting things done on a quick time frame. You're going to be working quickly to get things done because the patients want to get in and out. They want to go home. The surgeon wants to get in and out. Nobody wants to be delayed. Everyone's there to move quickly. And so you will be expected to move quickly as well. None of this 30-minute, 45-minute turnover times in between cases. None of this 15-20 minute times talking to patients in the pre-op area, taking a really long time getting prepared in pre-op. None of that really happens in the outpatient world. You move very quickly. You will learn how to become much more efficient while also making sure you're covering all of your safety. Another interesting aspect that some of you may not expect is that your relationship with surgeons is very different in the private practice world versus the hospital world. In the hospital world, sometimes you will not really care whether the surgeon likes something or not, or they like your anesthetic plan or not. Sometimes it's a little bit of an adversarial relationship, or the surgeon gets frustrated and you just say, tough, walk it off or something. And it's a lot less collaborative in a lot of situations in the hospital setting. Sometimes it is collaborative, but I'm just telling you there will be instances where it's not. And in the private practice world, it's small. It's possibly maybe 6 or 8 different surgeons operate at this surgery center, and they're there every single week, and you see them all the time, and you're going to be working with them very frequently. And there's maybe 6 or 8 anesthesia providers that ever come to this facility. So you really need to get along with each other. It's much more like a family environment. And there will be times as the anesthesia provider where you could do a MAC, you could do this case under monitored anesthesia care or sedation type case, or you could do it with an LMA, or you could do it with an endotracheal tube. There's a lot of different ways you could do a case, and that's true with anesthesia in general. There's lots of different ways you can do it. And typically, I don't care the way, in the past, I never even factored in the idea of what the surgeon would prefer. I pretty much did what I thought was best for me and the patient. Well, in private practice, you'll take into account what the surgeon thinks. If the surgeon is saying, hey, I really don't like, I would really prefer a general for these types of cases, because if they move at all, it really alters my, my movements and what I'm doing and stuff like that. So you'll say, oh, okay, I see. Well, I'll talk to them about a general then and see if they're okay. And if the patient's okay with it and I'm okay with it and the surgeon wants it, then we'll do a general. So in that sense, it will change, and you will actually have a much more of like a friendly, interactive relationship is the best way I can put it. You will start to consider the surgeon a lot more than you did before. And that's good. I mean, I like doing that, but it's definitely a different change of pace, your mindset in regarding your anesthetic plan and the way you practice and what you do. Suddenly you're incorporating a different person's perspective that maybe wasn't that important to you before. One more thing that I want to tell you about private practice is you're going to prescribe your pre-op medicines, you're going to prescribe your post-op medicines, you're going to write orders. A lot of the staff are going to regard you as, a high-level provider. You are their anesthesia provider. You are the only one they have to talk to about this patient, whether it's regarding pre-op or post-op or whatever. So you're in the hospital setting, there's a whole team of you, and there's usually a board runner and people who they will call when they have problems or questions. They'll usually call the board runner for all these types of things. Well, in private practice, they won't, because there's no board runner. It's just you. So they're going to call you. If they have a question, if the patient's acting weird and PACU, and they're going to call you or go to you and say, hey, this is happening or that's happening. What do you want me to do? If something's happening in pre-op and they're like, hey, I don't know, this EKG looks weird, or hey, what do you think about this? They're going to go to you and say, hey, what do you want to do? And you're going to have to make decisions about that kind of stuff. And the other thing that you'll need to remember is at the end of the day, when you drop your patient off in the recovery room, say it's 4 or 5 p.m. and you're staying a little late, and this is kind of later than you like to stay in the surgery center, but you're the last one to finish your room. All the other people went home. The surgeon just walked out the door. All the rest of the staff went home except 1 or 2 PACU nurses. You cannot leave until that patient, or you should not leave. I'll put it that way. You should not leave until that patient is awake and alert enough to be discharged home and is pretty much through the woods and met discharge criteria. Because if there was an emergency or something to happen, you are the only provider left at that facility. So you do have to remain. And also, while you'll find a lot of private practice people, anesthesia providers, don't give a bunch of like heavy-handed, long-acting narcotics at the end of their cases, because those patients will sleep for 2 hours in the recovery room, and you will stay there and watch them sleep until they're awake enough to be discharged home safely. So remember that about outpatient and being independent providers. There is no PACU person who just sits there watching those patients. It's you who will watch them if you're heavy-handed with your narcotics and they sleep for 2 hours. Well, all right, guys, I have got to go. I've got a mock interview to do, actually. If you guys need a mock interview, hit me up in the comments below. There's a Calendly link that you can go to, and I may put it in the description. But mock interviews for CRNA School or strategy sessions, I do those. Of course, the memberships you can join. If you have not subscribed to this channel yet, what are you doing? Join. Every week we come back with another video. Sometimes I miss, but usually every week. And on Instagram and TikTok, I'm putting out stuff over there too. Until next time, that's Bolt out.